My name is Jamie Moses. I work with Dr. David Huffman. We do endocrinology at University Diabetes and Endocrine. So we're going to talk about prediabetes and early intervention and prevention. I think I'm doing that right. Okay, so I have nothing to disclose. So statistics, I'm not going to give you a lot of statistics and tell you all of the things that you could read on the internet because I feel like that's not the most important thing for me to spend my time on. But look at the statistics. 1 in 3 of adults will have prediabetes. It's 96 million people. Think about this. 9 out of 10 of you in this room, if I grouped 10 of you together, wouldn't know that you have prediabetes. Probably the biggest reason why is because no one goes to the doctor. 19% are told by their doctor. The reason they don't know is maybe insurance, lack of time, jobs won't let them off. But what if they come in for a cold, thinking about primary care? Could you do an A1C? Could you do a CMP? Could you potentially change their course without even knowing it? And you could. So there are risk factors, being over 35, being obese, being of certain ethnic group. Think of Shaw Industries. There's a lot of Latinos in that population. I see some of them for diabetes. So if we look at these risk factors when they come in for a simple issue, maybe we can catch it. Maybe we can try to prevent going down the path of diabetes. Other risk factors, being overweight, it's not even obesity. It's just being overweight, so a BMI of 25. Having a history of CAD, of course, you're learning today about PVD, PAD. So if we can prevent that too, that's great. So what does it mean to have prediabetes? In our world, we don't really call it prediabetes, we call it abnormal glucose levels. Anything above 100 is abnormal. So normal blood sugar is 70 to 100. No, that's not my blood sugar. And an average glucose can give you an indication of what your A1C will be. But an A1C for prediabetes is 5.7 to 6.4. But when should we worry? Should we worry when they come in with a 5.8? Well, some of you might go, no, that's a decent A1C. We'll let them walk out the door. Should we worry when they're 6.4? I would really hope so. I see people come in all the time and they're past that pre-diabetes, they're already in the diabetes state. So if we change how we look at the labs, we would be more aggressive. We would think about how can I change their future? If we've gotten an A1C that's elevated, there are some labs we can do. We could look at a C-peptide to look at their insulin resistance. Sometimes showing people the labs is one of the best ways to get them to kind of gear themselves thinking differently about their disease process. We also shouldn't just group everyone as potentially having type 2. Their family history might show type 2, and we know that prediabetes, that's a higher indication of type 2 in the future, but maybe they don't. Maybe we should look at the diabetes antibodies to verify what we think is going on. You know, there's many new medicines out there that can help us with this, but we have to target the real issue, and if we don't, the medicines don't work. So we have to think about prevention. So prevention can be many different things, and what is best for the patient? How can we help them? So we can look at apps on the phone because that's accessible to a majority of our patients. Calorie King is a great app. It's only available on the iPhone. The Android, you'll just have to look it up on the internet and make it one of your favorites. But it will tell you how many carbohydrates, the sodium, the percentage of fat, all of those things. Because when you go out to a restaurant, you may not know what you're eating. And I had a gentleman one time go, oh, I love to get this from Applebee's, it's the best. And he was having swelling in his legs. And I go, let's look at Calorie King. And I pulled it up and I said, that has 1,800 milligrams of sodium. And he goes, that's probably why my legs are swelling. And I said, you're probably right. And then I've had other patients use Noom. They find that very helpful. You've got MyFitnessPal, you've got meal planners, and even the CDC has, and I didn't know where to put this one, and it could go on the next screen. They have a National Diabetes Prevention Program, as well as the YMCA, which I put under the exercise, but I'll get into that in a second. The other thing we can do is send them to a dietitian. I'm blessed to have a dietitian in our office, so I just say, hey, let's go and see our dietitian. Let me make a follow-up appointment with her. Those dietitians give a lot of nutrient information. They can do a nutrient evaluation to look at what is their intake versus output. COVID did a lot of good for prediabetes patients, let me just tell you. Everybody sits at home now, so their activity is down. So intake versus output, they might be eating the same, but 3 years ago they were out walking after work. Now they just stay at home because they work extra. They also can help with mindful eating techniques. I've got a lot of stress eaters, so if we can help them mindfully think of what they're eating and how we can potentially change that, they can do better. And always encouragement and praise accomplishments. I think they do that better than we do, to be honest, and I do really hard to try to praise people. But when you're in the room and you're rushed and you're trying to get to the next patient because you got 15 minutes, you kind of forget to tell them, you're doing a great job, keep it up. But the dietitian has more time to spend with them, so I always think, how can I help encourage and praise my patients? So think about that when you're talking to your patients as well. So exercise, 30 minutes, 5 days a week. I don't do that. I need to. Do my patients do it? No, not really. Reducing your weight by 5 to 7% will reduce your risk of prediabetes and type 2 diabetes. I try to find ways of incorporating activity into their lifestyle. So if they work at home, I'll go, look, after lunch, go walk 10 minutes. After supper, go walk 10 minutes. It's not a lot, but it will add up. And if I can incorporate the 10, then maybe next time I'll say, well, try 15, try 20, try 30. It will all add up and help reduce those glucose levels, help reduce weight, overall make them feel better. I did try contacting the YMCA here in town. They do have a prevention program nationally that can be done online as well as in person. They have classes. The ones in person, you can do an hour exercise program. They have coaches, they have nutritionists that work with them. So that might be something that you could work with your patients on and get them set up with that. And then let's be realistic, be specific, and also have forgiveness. I'll have a lot of people that get so mad that they didn't do what they needed to do, they quit doing what I asked them to do. So if we just go, okay, maybe 5 pounds, not 10, not 20, it'll be okay. And I tell people all the time, look, today might not have been a good day, but tomorrow can be better. Don't look at your failures as something that's going to keep going. We've got to look at the positives as well. Realistic. Society does not make it realistic. They see the lady from The Biggest Loser, she lost a lot of weight. But if you look at the Biggest Losers nowadays, they probably gain their weight back. So having a plan, making it something that's attainable, it will be a long-term success for them. So, how can we help them look at their blood sugars? As you know, there's meters, they've been around for years. Now we've got sensors. To get insurances to cover a glucose monitoring system, you might get away with it using an abnormal glucose level diagnosis code. Some insurances are just really great and they pay for it. Others, they don't. So Libre's probably the cheapest you could get out there. If you could just give them a sample, if the Libre or the Dexcom reps come in your office, get a sample, let them try it for 2 weeks to a month. I bet you their A1C will come down. I bet you their glucose levels will come down. I had a patient recently that the only thing I could do for her because she was strapped financially is I gave her 2 Libres and I said, wear it for a month, let me look at it, let me see if I can make some changes. I didn't hear back from her. Crickets, of course. She came back Her A1C went from a 7.9 to a 7.1. Is it ideal? It's not where I want her to be, but that's a big change. I said, what happened? She goes, the sensor. I looked at what I ate, and I said, well, that went up. Maybe if I cut it down. And then she cut it out because she realized that her blood sugars kept going up, and it wasn't worth having the high blood sugars. So they really do make a difference. If you did nothing at all and you gave them a sensor, they would come back and things would improve. So there are certain types of medications we can use. We can use metformin, which is one of the tried and true. Just make sure they take it after a meal so their GI side effects are reduced. You can do like Januvia, Tradjenta, which are in the DPP-4 category. I have known from personal experience that their A1C can drop 0.5 to a whole point just with adding those. And those can be covered quite easily under abnormal glucose levels. SGLT2s, they're easy to get approved. The one caveat I would recommend is make sure they get enough water. If you aren't getting 60 ounces of water a day, you're probably going to be dehydrated. Also, if they're on a blood pressure medicine, be mindful of that, because if you start an SGLT2 and their blood pressure is already at a normal level and you add this on, you could potentially cause hypotension. And of course, the last group we all know and love or hate to love is the GLP-1 GIP. Years ago, this was really easy to get approved for my abnormal glucose level patients. Because of the craze, unless you have type 2, you're not getting it approved. But there is Wegovy, so if they have the obesity category and their insurance covers it, or you can use the savings card, that might work. So keep that in mind. Takeaways: evaluate, evaluate, evaluate. If we never look at the patient's history, we never take the time to obtain an A1C, we never give them the information that, hey, this could lead to diabetes, guess what? They're gonna walk in your door, they'll have an event, they'll have had an MI, a stroke, PAD, and they're a train wreck. Now they've got 15 medicines instead of 3, and then you go, oh shoot, they've got diabetes. I don't like diabetes. What am I gonna do with them? I'm gonna send them to endo. But the damage is done, so we need to try to keep that from occurring. So treat earlier than later. And there's no magic treatment. There's exercise, there's dieting, there's medications, positive praise and encouragement. Everything works together. As you tell people all the time, I'm sure, there's no magic pill. There's nothing that's going to just magically make this go away. So, having said that, if you have any questions, feel free to find me afterwards. I'll be glad to answer them. But thank you very much. Appreciate it.
How's everybody? Got to wake up, all right? I'm Brandy Biederman. I'm a nurse practitioner out of Hickson. Endocrinology, diabetes, and thyroid. I've been practicing for a little over 15 years. We handle, like I said, specifically diabetes, thyroid, anything in that area. Most of my colleagues call me Dr. Diva. I do approach diabetes a little bit differently in my practice. I've had type 1 since I was 12. Hashi since I was 14. Endocrine kind of picked me. So when the patients come in, they want to know. They want to know what I'm doing. They want to know why it's different. They want to know how to get the results. Providers that are referring, they know what they can expect, and they want reciprocated results. They want action with these patients. They want improvement, they want numbers, they want happiness in these patients. Nobody wants to say, oh my God, I have type 2. Nobody wants to say I have type 1. You have to be able to click with these patients, get them on board and get them motivated and get them where they need to be, or you see the faith that comes from all these pictures you guys have. I'm gonna tell you, I don't have these pictures in my presentation, so we're gonna be okay. But, so we're gonna talk about clinical presentation, IDing that patient, early initiation of treatment, CGM options, utilization of GLP-1 GIP, SGL2 inhibitors, and insulin therapies. I am not that person that's gonna put a patient on MDI, okay? I'm gonna talk to that patient and we're gonna find out a better option. But when they come in, if you're looking at a type 2, we're looking at weight gain, fatigue, hot and cold flashes, uncontrollable cravings. These patients come in, they don't feel good. They're gaining weight. They're miserable. They have no energy. You guys had lunch, I guess, before all these kind of broke out in these sessions. But after they eat, they're hot, they're tired, they're having to go to the bathroom, they're not motivated, they're not going to be performing at their highest level at their job that day. So they're going to come in and they're going to be pretty miserable and they're going to talk to you. You're going to have to differentiate between prediabetes, type 2, again, utilizing insulin levels, C-peptide, A1C. A lot of people are quick to throw a type 2 diagnosis on board, and I don't like that. They're also quick to throw insulin at patients. That's not how it should be. In my practice, insulin is going to be literally a last-ditch have-to effort in a type 2 situation. In a type 1, that's obviously different. But you're looking at different criteria to diagnose: random over 200, A1C 6.5 or higher, prediabetes is going to hit 5, 7, 6, 4, fasting insulin greater than 20, obviously anything greater than 40 in a fed situation, C-peptide greater than 4, and again, you can use your clinical decision skills on those numbers. First sign of prediabetes, insulin resistance, you want to start treating. By the time I get a referral, you got an A1C in 8.5, 9 from some primaries in Chattanooga, and that's exhausting. You should be treating these patients earlier. It's not difficult, okay? You can throw any of these agents at these patients, get them better, get them to us, let us take over. I'm glad to diagnose and get in treatment far before I have to call them a type 2. And again, the type 1 patient, we're going to look at antibodies, utilize insulin, CGM immediately. But again, those patients are generally getting ID'd at the ER. If they're not, you're getting the antibody panel. It's going to take about a week to come back, and then you're going to treat them accordingly. So early initiation, the blood work that you're getting, and a lot of people have my panel that refer to me. They know what I need before I see that patient. We're talking just the things we've already talked about. And then time analytics, if you're treating a patient off an A1C, I'm going to be straight with you, it's archaic. You can look at it, you can use it to diagnose initially if you have to, but that's not reality. You can have an A1C in the 40s, 300s, bouncing back and forth, and you're still going to have a somewhat decent A1C. That's not going to get you what you need. You want time in range. We use Libres. Occasionally, they're not my favorite. I'm a Dexcom girl because I like the following. I like to be able to see the patients. I like to monitor most of my patients on my own devices. I'm a little bit of a control freak in that respect, but I also like to use the Gluco app so that I can see 100% of what they're doing the minute they come in. And then Senseonics is the implanted sensor. I'm using that. You insert it much like you would the birth control device Nexplanon. It goes in the arm here. It's inserted, and you insert it for 6 months, you remove it, replace it. The patient simply puts a receiver over it. So what do you get? You don't have to worry about them changing it every 10 to 14 days. You don't have to worry about them knocking it off every time they go through a door facing and hearing them complain about it only lasted 2 days, or the technology is not there. I mean, that's just ridiculous in this day and age. We have better choices. But a Dexcom may be a great option for some patients. Libre might even be a great option if they're Medicare or have no money. But the Senseonics, again, I'm about choice. Diabetes is not going to come out and be cookie cutter. Everybody's different. What works for me is not going to work for somebody else. But I do try everything because I want to have a valid decision on it. So time and range contributes more to overall understanding, and those patients know what I'm looking for. I'm looking for a glucose anywhere from 65 to not much over 150. I'd like it tighter, but I want it in that range 80% of the time, 85 if I can get it there. The patients know that I run a tight ship, and that's where I'm driving all of their interest, because I don't want to have to send them for an amputation. I don't want to have to send them for these things that everybody's like, well, my grandfather lost his leg. Nobody wants to talk about that. You don't have to have the death sentence from diabetes that we used to. So utilization of GLP-1 agonists and GIP, I'll tell you, they call me the queen of these. This is my class, okay? I love this drug more than anybody else. I speak on all of these drugs. I probably should have disclosed that in the beginning. But when it comes to GLP-1, that was my thesis, my doctorate, my postdoc. That was my world. This class of hormones is life-altering. For the first time in my practice, utilizing these, I don't have to say, you're going to progress to a type 2. I can prevent that with you. I can teach you what to do. Now, people come in and they're like, oh my God, I saw on TikTok, it's going to make me sick. No, it's not. You need to educate patients. This is a hormone, okay? We're activating gut hormones, GLP-1 or GIP. People who get on there and think they can eat like they used to, you're gonna get sick, okay? They're gonna be TikTok famous. It's gonna be bad. And there's probably 20 of you in this room that have tried it. God help us, don't raise your hand, but I'm just saying. There's a way to educate your patient. Now, I don't have a tattoo, but if I ever get one, it's gonna be Brandy's Fast 5, all right? What do I want you eating when you're using these hormones? Meat, cheese, eggs, nuts, and real vegetables. What does that mean? That means not a potato. I don't care what color it is, okay? It does not matter. We're also from the South. When I say no beans, I mean no pinto beans, okay? These people get a little nuts. We eat differently than just about anybody else in the world, and it does not go along well with this drug. But you educate them on where to give it. I love when patients come in and they're like, ha, I gave my shot right here. I'm like, why? Why would you inject there? Clearly we know where the receptors are, and clearly we know that we need to give it in adipose tissue, but they saw it where? Social media. These people are the devil. So get your patients in, draw them in, and teach them what they need to know. Say, come to me, come to the source. Okay, I'm going to show you what's the right way to do this. And if you have a question, call my staff. Call me. I'll walk out of a room to keep people from doing stupid things on Insta and socials and all these things. So again, here's another hot button for me, and if you sell this in your office, don't throw things. I'm not a fan of compound, okay? I do not want people using, in what to my mind, dirty drugs. So if you're selling it, again, you can trash me after the program, that's fine. I prefer to get pharmaceutical grade. Is it expensive? Yes, but these people are laying down more than this for Botox every month, okay? My population may be different than most, but I'm telling you, if you wave the obesity flag, say you're probably not gonna develop type 2 if you do what I say, they're gonna lay down the cash. So what can I do? I can get it for around $400 a month in the tirzepatide space, and I can tell you how to do that if we need to. But again, coverage is good if you know the coding and you know the way around it. And I've been bonus my PA guy on his percentage of approvals at the end of the week, so he does not like to disappoint. So we work pretty hard on PAs. We get everything done that we can, because I don't like to tell people no. We have injectable, we have oral forms, we have semaglutide, we've got tirzepatide. You can go back to Trulicity if you want to. I mean, we can take it way back to B-size. We can go all the way back. But what people are going to come to you for is semaglutide and tirzepatide. These are the big dogs today. They may want Rybelsus. They'll change their mind when they see the amount of weight loss they're actually getting. All right, I told you. I don't play around, I hit right to the core. So SGLT2 inhibitors, we've got IMPA, we've got DAPA. I'm a big fan of Jardiance. It's only oral. I like it a lot because what I see, even in my insulin resistance, my PCOS patients, I see that fluid retention. You get that fluid. You look at their ankles at the end of the day, they got that sock ring, they're miserable, they feel like they're putting on all this extra weight, their rings are tight, their wrists are tight. You put this on board, we see better glucose, we see better weight, because it actually blocks up to 600 calories a day. And show me a type 2 or a pre-diabetic who does not need that in their life. You guys good? Am I going too fast? Cool. Stop me if you want to. Insulin therapies. So let's talk about insulin. I said I'm not a big fan of MDI. Okay, every time I see somebody writing Levemir, I just roll my eyes, or Lantus, and they're splitting the dose. I mean, this is archaic. They're only doing this if they can't afford other things. And we even have cheaper biosimilars at this point. Tresiba and Toujeo are fine for long actings. People used to say, well, what about Novolog? What about Humalog? You're really not going to hear those anymore. They don't even sample much of that anymore. Today you're going to hear Lumjev and Fiasp. Again, we know it's a marketing thing because they need the money off that contract, but those are the rapids that we're mostly using. And I don't know what you guys know about Afrezza, but I don't want you out there being blindsided by it. Afrezza is an inhaled insulin. I am a huge fan of it because why? When you have a kid come in, or it's not legal in kids, let me rephrase that. When you have a college kid come in over 18 and they don't want to do injections, or they don't want to wear a pump, or they're on Hinged or some dating app and they don't want to reveal that they've got a pump on and a tube, if they're using a tubed pump, because we have pod pumps too. We have so many options, that's what I'm saying. But Afrezza, I actually brought my inhaler if you want to see it. Now mine is bedazzled, don't expect yours to come out this way. But so basically you pop it open, you throw an insulin cartridge in it, you close that bad boy. It's a vape, guys. It's socially accepted. tell you how much I'm at a bar, people come up and say, can I hit that? Probably not. But what I say is, come on, because what? People don't want to be like, hey, it's our first date. Let me screw this pin needle on my pen. Give me a little shot right here in front of God and everybody. And people ask all these questions. No, but nobody cares if you're like, I'm good, how's your night? You know what I'm saying? These are things. So what do I gain from this? I write a prescription for inhaled insulin. It's not bad to stack. It's in and out of your system like 45 minutes. And guess what? I get compliance. I get goal. I get numbers. I get people keeping their kidney function and their legs. It makes my life easy. Only caveat I'm going to tell you in a type 1 situation is you have to use this with long acting. Okay, this is not basal. This is only bolus. But you can hit it or not hit it as much as you want. And it's convenient. It's in your pocket. It's in your bra. It's wherever you need it. I'm not showing you what else is in there. Okay, but anyway, all right. So that should answer the Afrezza. As far as pump therapies, pumps have been around since Jesus was born, guys. So you've seen the Medtronics, you've seen the tubes, they're out there. I've worn one since I was 12 years old. Now we have pods, which run off either the little PDM they give you, the Droid app is currently active, the iPhone app has just gotten approved, we're expecting it early summer, so things are getting easier. So that runs the little pod with no tube, and you're welcome to that. There's a new one that just came out, it's really not that new, but they're just now pushing it, it's Beta Bionics. They're kind of marketing it towards more rural areas that don't want to calculate basal rates. But the smarter pumps these days have excellent algorithms, so you're not having to do things like back 20 years ago when I started, and you're having to sit there and calculate a basal rate and change it every 3 months when they come in based on the season changes and their activity changes and whatever sweet, inappropriate snack they're trying to eat these days. What is it now, crumble cookies or this all about bunt or whatever, I don't know, these cakes. I mean, these people are eating all of the things. But Tandem's out there, I'm not a huge fan, but again, it's a tubed pump. I'm not a huge tubed pump fan, but Medtronic's out there, Beta Bionics, those are all tubed. Pod is just what it says, a pod, there's no tube. And then again, it's options, okay? When I started, I opened the cabinet and it was like metformin, God help me, maybe a TZD, maybe something scary like that, but now I open my cabinet and it's like Baskin Robbins. I got 31 flavors. I'm dialing this into my patients and I'm making them happy. They're walking out of there motivated, ready to go and ready to kill it and not get any more horrible side effects from this disease. You guys are great. Do we have more questions? Here's what I want you to remember. Early identification, I would much prefer you to treat them in a pre-diabetes phase and to have to throw all these things at them in a legit type 2 phase. If you've got questions about coding, how to get things covered, how to motivate these guys, and how to keep them on board, I'm here for it. I love all my tools, my GLPs, my GIPs, my SGLT2s. I love my insulin if I have to use it. Remember, nobody wants to be overweight, okay? I'm hard-pressed to find somebody who's like, oh, go obesity, okay? Nobody wants to be overweight. But if you start stacking a bunch of sub-Q, you're going to have weight gain. It's going to make them angry. How many times do you see a patient, they're on 50 units of, God help me, Lantus or something scary like that. They come up 20 pounds heavier. Next time you see them, it's 70 units. I mean, you're not winning. You've got to break that cycle. You've got to throw something in to cancel out the resistance. You guys good? Have a great day.
Well, that's kind of a tough act to follow, huh? God bless. Yeah, I don't have any sparkly clothes on. I feel kind of ill-prepared for this. I always wondered who is the guy who followed the Beatles on the Ed Sullivan Show, you know, when the crowd was going crazy. I kind of feel like that person right now. But lo and behold, here I is. So, wound care, right? We'll talk about ulcers, and I thought I would kind of take a simplistic, not too simplistic approach to it and just sort of, you know, in order to treat ulcers, we need to know what we're dealing with, we need to know what we're working with, we need to know their depth, we need to know where they are. You know, how often do we see patients come in the office with an ulcer and they say, well, I've been taking antibiotics for 4 weeks and the thing hasn't gone away yet. So it's sort of not like, just like we learned with diabetes, it's not a one-size-fits-all. Most of the time a person comes in, general practitioner, they have an ulcer, they're given Keflex, they're given something. That's the treatment. I heard from somebody the other day I was talking with at the hospital that, a general practitioner saw a wound, they put Zeroform and gauze on it and said, come back in a month and we'll change it and see what we're dealing with, So in order to treat it, we need to know exactly what we're dealing with. The interesting thing is I use this slide every time I've spoken at this conference, every time I speak at a conference, this is the slide I use. And, you think I'd get some updated statistics. But the interesting thing is the reason why I'm using this slide is because I was saying, well, I got to prepare my lecture for Chris's meeting, for Dr. Lasar's meeting. So I need some updated statistics. So I entered 5-year mortality rate for patients with a diabetic ulcer. And the first thing that came up was Robbins Journal of American Podiatric Medical Association. The very first thing on the list in my research app, Dr. Google, came up this study. So after all these years, it's still this Robbins study, and we look at this histogram and we see everything on there except for amputation and neuropathic ulcer is some form of cancer. And right in the middle there at around 50% is an amputation. A little less than 50% is neuropathic ulcer. So we see that, the 5-year mortality for just having an ulcer is comparable to many cancers. But I went ahead and found a more recent one, and lo and behold, it's still kind of, we're still in this realm of about 50%. Minor amputation is around 50%. Major amputation, you're more proximal, you're below the knees. You're above the knees, we're above 50% 5-year mortality. Whereas 5-year mortality of something like breast cancer, is much lower than just having a diabetic foot ulcer, which is, on this one, this is 2020, is between 25 and 50%. So it's still relatively high 5-year mortality just for having an ulcer. And then, of course, let's incorporate many of our diabetic ulcer patients are also chronic renal failure patients. And now we're looking at a 2-year mortality of close to 74%. And then we look at the vascular literature, and there's oodles out there, but 80%, and we just saw that on that histogram, 80% 5-year mortality rate for non-traumatic amputation. 80% lower extremity amputations preceded by a foot ulcer, 80% of the non-traumatics. And not unusual. Risk factors for ulceration. We look at this, the top of this chart here is obviously, the foot pressure, the chronic trauma. So activity level, structural deformity. Do they have a bunion? Do they have a prominent metatarsal head? Do they have a bone spur? Do they have hammer toes? Do they have some prominence on their foot where there's going to be increased pressure to that site? Are the shoes they're wearing just too tight for the foot they have? They have a splay forefoot. They have bunion on one side, Taylor's bunion on the other side, a bunch of hammer toes, and they still want to stick their foot in a stiletto. Do they have a more advanced deformity, Charcot-arthropathy? Do they have Aquinas, a tight Achilles tendon? I heard at a meeting, and then somewhere in the literature, that Aquinas was dubbed the root of all evil. Repetitive trauma, ground reaction force. Ground reaction force is, remember high school physics, for every action there's an equal and opposite reaction. It's Newton's third law. When you strike the ground with a certain number of pounds of force, newtons of force, the ground is pushing right back at you with the same amount of force. And then shear forces, that's if obviously we're kind of rubbing that area when we walk. Do we hyperpronate, do we supinate to where we're going to share that area? Most people who come in with an ulcer say, well, it just started as a blister. And I have to tell them, well, it wasn't a blister, it's an ulcer. No, doc, it was a blister. Well, it's caused by shear forces, so it's going to start as a blister, but it is an ulcer. But that top one, pressure, and obviously they're diabetic. Look at the blood glucose levels, the A1C, are they under good control? Enzymatic debridement is still a very powerful tool. The only game in town is really xanthal collagenase. When I started in school and residency, we had a lot more armamentarium. We had the papain urea, the papain-urea chlorophylline products, which I thought were great, but they have since been pulled off the market, which is sad. So as of now, basic enzymatic debridement goes a long way. Xantho collagenase, normal saline moisten, wet to dry dressing, change daily is a great form of enzymatic debridement, and sadly the only form of enzymatic debridement. But let's go in. Just basic foot exam. Nothing fancy. Pedal pulses. Feel for a DP pulse. Feel for a posterior tibial artery pulse. Elevation dependency. Do they have rubor? Is their foot warm? Is it cold? Do they have digital hair? Is it diminished? In other words, they have hair. They're fine. Well, do they have hair or do they have diminished? If they have one little hair on the third toe, doesn't mean, they're healthy. That's diminished. We always want to say they have no digital hair. Really, realistically, on an exam, it's diminished. Capillary refill time, your basic ABIs, your arterial ultrasound and Dopplers. These can be powerful tools. Pedal pulse, here we are looking at a posterior tibial artery pulse. Simple as that. This is my, hey, how are you? Good to see you again. How you been? How the kids? While I'm having, while I'm kibitzing with the patient when they first come in, I'm feeling for pulses. And then here's the good old-fashioned ankle brachial index, an oldie but goodie. It can be a very, very powerful tool. It's a very basic comparison of the blood pressure in the ankle to the blood pressure in the arm. And it's a ratio, right? Blood pressure in the ankle over blood pressure in the arm. If it's equal, I tell my patients you're 100%, right? Well, your circulation's 90% of normal, it's 80% of normal, it's 60% of normal, and obviously the lower that ratio gets, the more severe we can associate it with the patient's circulatory disease. And the one caveat is if they come in and their A1C is 1.4, well, now we have to assume that they have some sort of arterial sclerosis, which is not unusual, especially in our diabetics, calcification of the arteries. So that can give you obviously a false positive. And then sometimes you'll get this, you'll ask for an ABI and you'll get this report back. ABIs cannot be taken as the arteries are non-compressible. Neurologic exam. Once again, we don't have to get fancy. We don't have to send them for a nerve conduction study. I have so many patients with diabetes who say, Doc, I got sent for this nerve conduction study. Guess what they said? You have neuropathy? How'd you know? Well, why don't, instead of sending them for a test where they get prodded with needles all the way up and down their lower extremity and then electrocuted, why don't we just, do a sharp dull test? Why don't we take a Sims-Weinstein monofilament and touch the bottom of their foot and see if they feel it? Take a gauze sponge and underneath the foot. Do they feel that? That's light touch right there. Do a simple muscle strength test, muscle examination. Anterior compartment, 5 out of 5. Is it 4 out of 5? Do they have some weakness? Do they have weakening of the muscles on the plantar foot? And they got these just sort of weird looking hammer toes that are just floating there. We call that a minus foot. It's from loss of innervation to the plantar muscles on the bottom of the foot. Lo and behold, foot doesn't look like much, but we have 4 layers of muscles on the plantar foot. There's a lot going on there to stabilize that foot that's otherwise making that foot unstable when they're not getting any signals from the nerves. And we don't have to send them for a nerve conduction study to determine that they have large fiber neuropathy when they've been diabetic for 15 years and their A1C is 9. Doesn't mean that that's not a good instrument or a good tool to be used, but really for this, no. And the interesting thing is, in the early stages of diabetic neuropathy, you send them for a nerve conduction study, it'll come back negative because it's a test of large fiber neuropathy, not small fiber neuropathy. If you do a nerve density, the epidermal nerve density fiber biopsy, you'll find diminished epidermal nerve fibers, which indicate polyneuropathy, but you're not going to see that in the early stages. So the patient's going to come in, they can't feel anything, they're developing an ulcer, and they're going to tell you, I don't have neuropathy. These are instruments from a neuro hammer, similar to just your standard reflex hammer, except these have a few extra toys on it. They can come with a light touch device, they can come with a sharp dull device. And then the oldie but goodie, still very reliable Sims-Weinstein monofilament. This is to mimic about 10 pounds of pressure or 5.07 grams of pressure. It is a very reliable instrument. The caveat is you got to use it properly. And number 2, you have to remind the patient that they're expecting to feel something sharp. It's like, I didn't feel anything. You have to remind them, do you feel it touching you? Not, do you feel a poke or anything like that? And the other thing too is, if they have this thick thing of callus underneath there, sometimes it's not as reliable. So in order to treat an ulcer, we need to know what we're dealing with. If they have a callus, if they come into your office and they have a callus under their foot, under a bony prominence, that's an ulcer. There's no bleeding, there's nothing open, there's no erythema, there's no pain, there's no nothing, it's just a callus. If it's under a bony prominence and they're a neuropathic diabetic, it is an ulcer. It is a grade 0 ulcer. There's no break in the epidermis yet, but if we leave that alone, there's going to be. So we need to treat that like an ulcer. These patients come in the office, we're going to trim that area, we're going to offload that area, we're going to put them in a prescription shoe. We're going to treat it like an ulcer because if we don't, it's going to become an ulcer, and then that's a lot bigger of a headache. And then obviously, your grade 1, your superficial ulcer. Is it intradermal? Is it sub-Q? We start getting to more full-thickness ulcers. We can track down the capsule now. Grade 3, we have osteomyelitis. Your grade 4, something's going to have to be removed, a toe, a forefoot. And grade 5, it's not salvageable. This is just another form of classification system. This, it's a little bit more complex. You're going to see a lot of the things I quote are from Armstrong. That's not intended. I'm not a David Armstrong groupie, nor did I train under him. I trained under a couple of guys who did train under him, so I guess. But he just happens to be in a lot of the wound care literature. And this is when he was at the University of Texas, San Antonio, they came up with this classification scheme. And the only reason why I show this is a classification scheme that incorporates infection, depth, infection, and ischemia. So it's a very complete system. It's the one I ended up using in residency because the people I was trained under were UTSA grads. They did the residency there. So I did this residency by default. And they are the ones who trained me in limb salvage, which I'm glad I had that time with them because it was very invaluable. I didn't expect to be doing as much wound care as I do. I ended up getting my second gig in Chattanooga, Tennessee. So I tell people I've done a 20-year fellowship in limb salvage and wound care. You're grade 0, it's a callus. Well, it doesn't look very scary, but in a diabetic it can be. That can turn into an ulcer very quick. This is your more grade 1 level. We're into the subcutis now. These are under bony prominences, they're under metatarsal heads. Now we're tracking the bone. Here's a patient with first ray resection. They have a transfer ulcer, second metatarsal head. That Q-tip, which is another very good diagnostic tool. A lot of these diagnostic tools aren't fancy, right? They're not expensive. It's a Q-tip. It's a monofilament. But this Q-tip goes all the way down to bone. That's osteomyelitis. And obviously we can see abscess formation extending to the toe. And then, getting in more to your Wagner 4s, it's more global. This is a patient that had a transmetatarsal amputation. I love giving this lecture before lunch. I'm so sad that I had to do it after lunch. This is so great what I did, is it Wagner 4, is it Wagner 5? Can we try to salvage this? Can we remove this eschar and put a graft on it? A lot of it's determined based really on circulation. And then Wagner 5, this is a patient I saw at Hamilton Medical Center, got called to the ER at 11 o'clock at night to do, they had this small abscess in their foot. The small abscess in their foot tracked into the anterior compartment. The whole plantar deep space was involved. You're staring at the head of the talus right there, that big white thing where the foot used to be. And, that's a Wagner 5. That was necrotizing fasciitis, gas gangrene all the way up the leg. There was a lot more than just that, and that unfortunately could not be salvaged. But sometimes necrotizing fasciitis can be. Here's another one of my Hamilton patients that we did a neck fasc on. And this was another one of those calls to the ER. This was a relatively younger person, but as you can see, that closed up. So you can salvage it. This is the vascular lab, Wagner 4. This is a case with Dr. Lassar we did. And, as he likes to tell our patients, he's the plumber, I'm the carpenter. So he went in, cleaned it out, and then right there on the table. So you see in the vascular lab, I just went and did my thing. And that's the patient on follow-up. They had that residual wound. I'm looking for, we were able to close it. I'm trying to find a picture of it. And what looks unsalvageable? Is it a 4? Is it a 5? Is it a 3? This is a 3 because this foot was salvageable. It started as a plantar puncture wound on the bottom there. You can see where the wound kind of at the a little bit at like the 5 o'clock or 6 o'clock position where it sort of delves into the plantar foot. This person stepped on something and they basically had an abscess and blow out of the entire lateral foot. You're staring at the peroneal tendons, you're staring at the lateral capsule, but we closed it. Patient was a real interesting dude too. So some things that don't, some people would look at that and say, oh, we can't save the foot. It's salvageable, and I've had patients where I've been kind of preparing them for amputation, and I remember one of those patients, and I think Dr. Lassar talked about it last time. Dr. Lassar said, just let me try an angio. Let's see what happens. And we did it, and lo and behold, the guy healed, and went to Mexico to visit his family, and came back and brought me a bottle of tequila. So it was all worth it. Transmetatarsal amputation is a very powerful limb salvage tool. This is your standard plantar. This is your standard transmetatarsal amputation. Make everything nice and even. You're trying to preserve what we call the metatarsal parabola. You got a good flap developed dorsally. You got a good flap developed plantarly. Just like it's like a BK, right? You're developing a good posterior flap, anterior flap. We flap that up. We sew it together. And final closure, a person can walk just fine on a transmet. It's a functional limb. The goal is a functional limb. Here's a Charcot foot, prominence there under the navicular cuneiform joint. This is your classic sort of what we call medial column collapse. Your medial column is your arch, your flexible part of the foot. The lateral column, obviously, is the lateral, more rigid part of the foot. So here's that, Charcot foot, that collapse. And you got that big prominence on the bottom of it right there. But one of the things that we noticed, I went back, Aquinas is the root of all evil, that calcaneus is kind of being pulled up. We have what we call a negative calcaneal inclination angle. If, in a lot of these cases, instead of going in and just rebuilding this foot, we just lengthen the Achilles tendon, a lot of the times that'll resolve the ulcer. And then other times we have to go in and we just fuse that medial column. We bring that medial column back up. We can repair and restore that arch height. And this is another patient, similar thing. And we got a little bit of ectopic bone left behind from, that just sort of just all blends in with everything, and it's almost like bone graft. But there's other things to alleviate pressure. A wedge shoe is a simple way to do that. Just take pressure off a forefoot ulcer like we saw earlier. Total contact casting is a very powerful tool. We do that a lot. So it doesn't all have to be surgical. But the big thing is to get pressure off of it. And then when you get that ulcer epithelialized, we have to remember that just because it's closed doesn't mean it's not there. It's the wound is in remission, right? We're borrowing something from our oncology friends. But, callus or blistering of skin, once again, is indicative of a site of ulcer. If you have a patient who's neuropathic and they have a callus underneath a metatarsal head or other bony prominence, treat it like an ulcer. Send them to a podiatrist, send them to a pedorthist, send them to an orthopedist, send them to somebody. It may be just as simple as me in the office trimming a callus. Take a 10-blade, trim the callus, do a quick exam, write a prescription for shoes. That's it. If it's a little bit more advanced, okay. We'll offload that ulcer. The big thing is getting pressure off that ulcer, and then once it's epithelialized, keeping an eye on these things. We in some cases what's the term? You end up marrying your patients. To death do us part. But we can extend the leash a little bit, so to speak. We don't have to see them every week, but maybe we see them every month, and we make sure if that hyperkeratosis at that ulcer site is building up, we trim it. It's a lot better than having to go back and do wound care and send them back to the hospital and lo and behold explain to them why they need an amputation when they thought this thing was closed. It saves a lot of heartache for your patient and for you. We don't want to see our patients suffer. And then, the classic, American Diabetes Association risk assessment. This thing's been around for a million years. I think this is 2008, and Dr. Ableton, who's a big endocrinologist in Britain, and there's Dave Armstrong again. Once again, I'm not an Armstrong groupie. Is no loss of protective sensation, no peripheral arterial disease, no deformity. They're low risk. We still want to see them biannually or annually, just do a checkup on them. But really, we're getting into the loss of protective sensation and deformity. That's when they come to see me. They have an ulcer. They're going to have an ulcer underneath the site of pressure. We need to do something to address the loss of protective sensation, which is protect them, put them in accommodative shoe wear, get the pressure off the ulcer site. Maybe we need to address the deformity. If they have a low A1C, if their diabetes is under good control and they have a bony prominence that we can alleviate, we can do a bunionectomy, we can do a hammer toe repair, fine. You know, if they have no pulses and their A1C is 11, I'm not going to schedule that patient for a bunionectomy. Unless I have a really good lawyer. And if they're a really good lawyer, they're going to say, why the hell did you do that? And then peripheral arterial disease and loss of protective sensation. Now we're getting Dr. Lasar involved. We're getting his group involved. We're getting vascular surgery involved. And obviously, a lot of patients that come in my office, unless they have bounding pulses, I'm sending them for just a basic arterial study and an ABI. And then the highest risk group, history of ulcer or amputation. The big thing is the right side of this chart. It's how often do you see them? A lot of my patients they have a healed transmetatarsal, they have a healed digital amp, they have an epithelialized ulceration. I'm seeing them monthly, at least. And they're perfectly fine with it because the patients know that if we don't have this regular follow-up, now we're risking reopening of their ulcers. And and the other tricky part of this too, because we're talking about just pressure alleviation as a means to treat an ulcer, is having that conversation with your patient that works 12 hours a day in a mill, and you get that first ray amputation healed, and they have 4 toes left, they have 4 metatarsals left, and they want to go back and work 12 hours a day. We have to have that conversation. Is your foot that now has this permanent deformity, is it capable of doing that? Do we need to look at doing something else? Because if you have a transfer ulcer, now we're looking at a transmetatarsal amputation. So there's a little bit of a lifestyle change too that we have to discuss with our patients. But this is just sort of a basic, we don't know what to treat unless we know what we're dealing with. It's not a one-size-fits-all thing. It could be surgical management, hospital admission, surgical debridement, multi-specialty involvement, infectious disease, vascular surgery, to as simple as trimming a callus and putting somebody in a diabetic shoe. It really depends on the severity of the ulcer. And if we don't know what we're looking at, how do we know how to treat it? Take-home thoughts, uncontrolled pressures. That's the big thing. Get pressure relief off the thing. Patient comes to my office, just like I said when I started, they've had 3 doses of Keflex and their ulcer hasn't gone away. Well, it's not infected, it's clean, it's granular, it's healthy, it's just underneath a bony prominence. What if we just put some dispersion padding underneath it? What if we get them in a special shoe, an orthotic, a wedge shoe, a total contact cast, whatever it may be, some means of just pressure relief. Their vascular status, obviously. If there's no blood flow getting to the foot, you can put all the magic grafts on it that are out there, your PureApplies, your Stravixes, all those things. But if there's no blood getting to it, no matter what you do to it, it ain't gonna heal. What looks salvageable? What looks unsalvageable? The goal is a functional limb, and I know this is sacrilege to say at a CLI meeting, but a prosthetic is a functional limb. And what do I mean by that? When the patient comes in with a severe Charcot arthropathy, and you can surgically salvage that foot, and they have 1 metatarsal and barely a heel, they're not going to be able to walk on that. So you have to be realistic with what your goal is for limb salvage. If their quality of life is going to be worse with what you give them limb salvage-wise, whereas opposed to them in a prosthetic and them actually having a better quality of life, you have to gauge that it's kind of a judgment call between you, the patient, other doctors. Sometimes amputation is the best option for patients. Do they want to have a wound vac change every day to try to save a foot that they're not going to be able to use in the first place, whereas they have a BKA and now they're up and about having a quality of life? Obviously we take into consideration the risks of amputation to the contralateral limb and everything, but it's, the goal ultimately that we're all looking for is a functional limb. And a prosthetic is a functional limb, and I know that's a no-no to say here, but it is. So I'm sorry I wasn't sparkly, but I hope I didn't bore the heck out of you. And I thank you for your time.
Good afternoon. So today I will be talking about diabetic peripheral neuropathy. This is something that is a challenge no matter what you have to face with it. The hardest part is trying to get a proper diagnosis for the patient and making sure that they're properly managed. So why is diabetic neuropathy so important to us? Well, 50% of all major amputations are associated with diabetes. Hyperglycemia, we know over long periods of time, ends up with nerve damage to the feet, and this results in foot ulcers. Those ulcers can become infected, and that results in infection or in amputation. And diabetic foot infections occupy more hospital beds every year than all other diabetic complications combined. So this is very important for us to be screening our patients for neuropathy so that we can manage this before it becomes to this level. There's several different types of diabetic neuropathy. For the most part, for the rest of my lecture today, I'll be talking about peripheral neuropathy. This is our distal symmetric, and this is our most common type. This is that progressive loss of sensation where it affects the feet and hands in that classic stocking and glove pattern. There is also autonomic or DAN, diabetic autonomic neuropathy, and this affects the homeostasis functions in our body. This typically starts happening in more advanced diabetes, where we get the gastroparesis, orthostatic hypotension. They're not aware that their blood sugar is dropping. And then we also get issues with sweating, and that leads to chronically dry skin. We also have proximal or the thoracic and lumbar radiculopathies. This is something to be mindful of because these will be patients that present with similar symptoms as PAD. They'll complain of pain to their thigh, hips, buttocks, and legs. It's difficult to walk or stand, and so it's important to screen these patients appropriately. And then there's also your mononeuropathies. These are your focal damages to single nerves. Oftentimes it can affect the cranial nerves and lead to vision issues. Your arms, you can get your medial nerve or median nerve, and that can affect grip strength. And your legs, you can end up with drop foot from common perineal issues. Something that is becoming more frequently seen is treatment-induced neuropathy, aka insulin neuritis. This is seen in patients with rapid improvement of their A1C. Typically, 2 or more points within 3 months can trigger a neuropathy. Of all of these, though, this is the one that can sometimes reverse, so that is nice about this. But it is something to be mindful of as we start using the Ozempic and using Libre and these monitoring devices. They're wonderful tools, and I've seen them drop my patients' A1Cs dramatically, which is great, but then they come in, I have neuropathy, I have pain in my feet now. Well, it's because that sugar just got fixed a little too quick. But thankfully, of all of these, that actually does tend to reverse itself. I could be here for the rest of today talking about pathology when it comes to nerve function. I won't do that. But the two main things that are important that happen with neuropathy development is how long you've had the disease. 50% of all diabetics will end up with a diagnosis of neuropathy within 25 years of being diabetic, and how severe their hyperglycemia is. Why does it affect the nerves? Typically, in our feet, we have the very long, unmyelinated sensory axons, and the longer they are, they're more susceptible to damage along that path. And because they're unmyelinated, they're unprotected. When that hyperglycemia affects the nerves in the body, we have what's called a dying back or a length-dependent damage to these very long axons, because these mitochondria, as they travel down, they're trying to provide those nutrients, but they peter out because of damage, whether it's from microvascular issues or from the hyperglycemia in and of itself, but they get damaged along the way. They can't provide those nutrients, and that's why you start seeing it from the feet, and it slowly progresses up. There are non-modifiable risk factors to be mindful of when you're taking a patient's history: coronary artery disease, hypertension, kidney disease. Taller patients have longer nerves. They are more susceptible to neuropathy, and older age. Some of the modifiable risk factors to be mindful of: uncontrolled blood sugar, smoking, hyperlipidemia, obesity, and very commonly alcohol abuse. That can cause worsening of any neuropathy in and of itself. But this is practically every patient that I deal with. So it's something that you need to be screening pretty much all patients for these. Symptoms will vary. I have some patients that will come in with just a numbness or tingling in their feet. As that disease process progresses, that's when you start getting pain, that sharp stabbing, shooting pain. Oftentimes it's worse at night, and patients are always curious as to why that is. That pain's there all the time, but when you have nothing distracting you at the end of the day and those nerves are just going to town, that's when patients notice it the most, and that can cause sleep disturbance. Some patients will describe hypersensitivity. It hurts so bad that they can't even put the sheets on their feet, and so they tent everything over their feet so that they don't have anything touching. As things progress, that's when we get muscle weakness. That's when we get those foot problems. Oftentimes hammer toes, where we get loss of that function. And so those are bony prominences that lead to ulcers, infections, and amputations. And the most scary of all of these is the asymptomatic patients. These are the ones that come in the middle of the night with the bone sticking out of their foot, septic, and they had no idea. They had no sensation that they had any issue with their foot at all until it became so bad that they're at risk of amputation. On exam, we look at it in a small fiber or the sensory testing versus large fiber. Small fibers are going to be affected first, and that's where you assess touch, pain, and temperature, and you compare that from toes versus the knees. The Sims-Weinstein monofilament testing, and then as the disease progresses, that's when it starts affecting your motor function. Muscle strength, deep tendon reflexes, proprioception, where you're identifying if the patient can see where their foot is located in different positions, vibratory sensation on any of the bony prominences, and a gait analysis. Neuropathy tends to progress into balance issues, and these patients then become more prone to fall. And just like Dr. Solomon had talked about, EMG, NCV, these are typically not what we order for classic diabetic neuropathy, but they can be helpful when you have abnormal symptoms in a patient. This is something that is useful to identify specific nerves that may need to be released surgically, or it may be something that you can refer to a neurologist. There is no cure for nerve damage. So many patients come to me and they ask, oh, okay, like how do we fix this? Well, there's no fix. The damage has been done. The goal is to help prevent it from getting worse, help manage the complications that are going to arise from it, and then relieve the pain if pain is present. In regards to pain, only about 20 to 30% of patients will come in with pain. There are no medications out there to help with non-painful neuropathy. So if you're trying to put a patient on medications, make sure that it's for their pain instead of just for their loss of sensation. In regards to treatments, pharmacologic treatments for diabetic painful neuropathy include antidepressants and anti-seizure medicine. Most commonly, duloxetine tends to be the most common. I think that that's the only FDA-approved antidepressant out there. It's very helpful for patients if they're not already on an antidepressant or something similar, and it tends to be better tolerated in our younger population. Anti-seizure medicines include gabapentin and Lyrica. I typically start patients on a low-dose gabapentin and then progress to Lyrica if they cannot tolerate it. And these are both very helpful for restless leg syndrome. Typically with side effects, both of these can cause somnolence, and so it is helpful, especially if the patient complains of that pain at night when they're trying to go to sleep. Have them start with the medication beforehand, and then that can help control the pain, and it'll make them sleepy. But if you start getting increased dosages and it's not working, instead of continuing to up that dose, try a combination of these two types of medications before you're going up on these doses. Non-pharmacologic treatments, most commonly out there is topical capsaicin. There is a gel form that you can prescribe patients, and then there are also capsaicin patches that are a much stronger dose, but these are typically done for 30 minutes in the office. A provider does it. The issue is that these cause a really bad burning. It's capsaicin from peppers, and so you're burning the patient to help deaden some of the nerves. Some patients tolerate it, some don't. There's also lidocaine patches that you can use to help pre-medicate for the capsaicin treatments. But again, none of these are perfect supplements. I do recommend any diabetic with neuropathy to be on supplements. A good multivitamin, especially with a B complex, is very good. That's great for nerve health. In particular, alpha lipoic acid. What that does, it just helps the oxidative stress in our body decrease a little bit, and it does help prevent it from progressing. TENS unit, spinal cord stimulation, acupuncture, physical therapy, these are all just adjunct tools to try and see what works and what doesn't. A lot of this is a trial and error for these patients. But the one thing in particular, opioids are not a treatment for painful neuropathy. And so we do not need to add to the opioid epidemic. And so there is no FDA approval for opioids for neuropathy. And just to end, the best thing that we can do is to help identify these patients and making sure that they are educated as best as possible with blood sugar management. If you have a patient with neuropathy, please get them to see a podiatrist. We can help manage calluses and help catch some of these things before it progresses to an ulcer that needs surgery or amputation. And then it's lifestyle modifications, weight loss, blood pressure, smoking cessation, and avoiding excess alcohol. But more than anything, if you can just get patients that have neuropathy to a podiatrist, we can help take care of things as best as we can. Thank you.